Let me know whenever you want me to start, Jens, or if you want
We'll do the little intro first,
to. Okay.
Dave, and then, so after the intro, and then I'll introduce you briefly, and then I'll do a second bigger introduction for your second talk.
Okay. By the way, I like what it says under us, Ted.
Welcome to the Seattle Science Foundation. We thank you for your interest over the past years in our regular programming, and we will continue to look forward to a great new 2025 program series. As always, we pride ourselves on offering free and widely available high-quality content, and I'm, as a spine surgeon, always very intrigued in learning from this. In 2025, to support our mission, we'll have to charge for CME credits, and this is doable through an all-access pass. This all-access pass will be differentiated for residents and fellows and for attending level or faculty surgeons. So please join us in the future. If you want to have CME credits, please do it through the all-access pass.
And we're live in 5,
4, 3,
2,
1.
Well, good morning, everybody. It's May 7th, 2025, and my name is Jens Chapman, and welcome to this very special edition of our STED Talks, Spine Technology Education, and the multi-potent D discovery. And today, the D is also for deference in regards to our special guest lecturer, Professor Dr. David Pauly Jr., immediately past retired Chief of Spine Surgery at the University of Minnesota and holder of the James Ogilvie Chair in Orthopedic Surgery and the Catherine Mills Davis Land Grant Chair in Biomechanical Engineering, retired with distinction U.S. Navy officer. So thank you, David, for joining us, and no HIPAA violation, but he's recently had spine surgery himself, so he is tough as can be and insightful. And in recognition of his great accomplishments and in honor of his retirement, and sadly I could not go to his retirement party, which I was honored to be invited to, but I was on call and had to do some work. We thought we'd do a double feature with him. So our usual program is to start some cases and then have the guest lecture, but in recognition of Dr. Dave Pauly's special accomplishments, we thought we'd switch it around, and he'll give 2 lectures. A first presentation will be highlights of developments in spine surgery and an over 30-year career in spine surgery, and we thought this is super interesting. And then we'll do the case presentations. So I think we have 4 cases presented. To present, and then we will have the second lecture, which is words of wisdom to the next generation. So I hope you, the audience, and we appreciate you tuning in, will find this interesting. We're, by the way, very honored. You see a new face in front of us. Dr. Cristobal Castillo from Chile, the Chilean Orthopedic Society has sent him here from Santiago de Chile, and we love our Chilean colleagues, and I've had great times there. So looking forward to a great month with Dr. Castillo. Welcome here. Without much further ado, we have Professor Pauly live from Minnesota. And Dr. Pauly, share with us what highlights of spine developments you've discovered over your past 30 years. And thank you so much for joining us and braving the immediate post-op period by speaking for the next hour and a half.
Thank you, Jens, and the whole SSF team. I have to say that it has been a privilege to be there many times at the Seattle Science Foundation, and occasionally we even got to see the mountains through the clouds. And so I love the programs that you run. You have a great lab, and I love the teaching efforts that you all take on. So again, a shout out to Seattle Science Foundation for all the great work that you've done over several decades now. So this is a story of my career and what that pathway has been. So I graduated from medical school in 1985, and I was involved in a Harrington rod case as a medical student. During residency, Steffi plates were a very new thing. One of the first places that did CD instrumentation in the US was at Walter Reed Army Medical Center, where I did my training. And we had some kind of hit or miss neuromonitoring. Then I did my spine fellowship in Minnesota, and the big deal was, could you do the 3 instrumentation systems that existed at the time, CD, ISOLA, and TSRH? And there I first saw neuromonitoring become more reliable. So my primary first love is probably adolescent idiopathic scoliosis. And that when I started, hooks were the way that we corrected scoliosis. And then the group out of Boston revolutionized the US experience by saying, okay, can we do pedicle screws in the lumbar spine as Steffi plates were becoming more common? And so this led to the effort to start using pedicle screws. And so I started looking, I would get CT scans on the lumbar spine of my scoliosis patients to see if in fact the pedicles were big enough for screws, because we didn't have that many small screws at that time. And they could never get the protocol quite right. And that I was always under the impression that pedicles got bigger as you went from cephalad to caudal. And that with the CT scans not always being centered right, I started looking at T12, and T12 was almost always bigger than L1. And it's like, maybe we can put pedicle screws in the thoracic spine. If we're putting them at L1, we're at conus level already. And if the pedicle is bigger at T12, why wouldn't we put screws at T12? So the paper that changed the world in the scoliosis world was when Professor Suk from Korea first reported his use of thoracic pedicle screws. I think the initial response in the United States is he's got to be crazy. Why would anybody do that? But his results were compelling, and he had a number of visitors, and that started to change the world in terms of how we thought about correcting the thoracic spine. So again, from Walter Reed, here are 2 similar cases of mine, and thoracic pedicle screws showed us that we probably could save levels compared to what we were doing with hooks at that time. So Ron Lehman was one of my superstar residents, and this is, as far as I know, the first entry point map for thoracic pedicle screws. It was very sophisticated. We put K-wires in using the anatomic versus the straightforward, and we put pencil erasers, green on one side and white on the other, to differentiate them. It was very high tech at the time. And this is what the study that Ron did. When Larry Linke and I were teaching a course together about thoracic pedicle screws, we thought we were doing the same thing. We found out we were doing different things. So he was doing everything freehand and using the straightforward technique. I was doing it fluoro-based, and I was just following the course of the pedicle. And so that was the anatomic trajectory. And Larry really loved that. What we proved was that the straightforward technique had better insertional torque. But what we also studied using navigation technology was that we found that the anatomic trajectory almost always had a bigger bony channel. And so that's an important fallback, especially if the pedicle is small or if you're trying to salvage, you can alternate one versus the other. Then we reported our first series of pedicle screws in 2000 at the SRS in Australia. And I think what made this believable to the US surgeons was I showed my best, such as figure 1, and I showed my worst cases, such as figures 2 and 3. And that these are, someone trying to be honest about this is what our initial experience was. There were no neurologic deficits. That middle image was a Scheuermann's patient who I saw multiple years post-op, and they really didn't want that screw changed. And it was like, okay. As opposed to figure 3, where I was very uncomfortable about the proximity of the screw to the pulsatile aorta. And so I talked to the family and I took that patient back and removed that particular screw. But being honest about let's see our best and let's see our worst, I think is something that is incumbent upon us. And anybody who tells me, oh, I've done 100 of these and they've all been perfect, okay, I don't need to listen to much more. Someone who tells me, well, I've done this and 87% of the time it works really well. Here are the challenges that we've had in the other 13%. I want to listen to every word that that person has to say. So this was when I returned to Minnesota in 2003, we were still using wet plain films for our scoliosis cases and the Jackson table and how it looked. And then we moved into the era of navigation. For me, this was end of 2006, beginning of 2007. And I had one of the engineering professors in the in the OR with me, and we took this series of images. So this is a perfect trajectory through a prior fusion mass in a pedicle. This is out medial and this is out lateral. And then the question is, how good are you, and are you good enough to be that precise? And I think we've gotten a lot better at pedicle screws, but throw a fusion mass over top, distort the landmarks, and it gets a little more challenging. And so these are the kinds of cases that we were regularly doing with navigation, and having safe placement of screws and good correction of deformity, better than I could have gotten with other strategies. I think probably when Jens and I started, this would have probably been a front-back case, maybe even a 3-stage to try to get that kind of correction. So we looked at our initial cohort, no training series. Noel Larson, who was my partner at the time, looked this up, and we found that at a threshold of about 4 millimeters of a outer diameter of the pedicle, our accuracy probably started to deteriorate, but that in general, we did pretty well with our pedicle screw placements. And we tried to say, all right, so with navigation, we have a virtual screw placement, and then we have an actual screw placement. So we got started in our process of screw placement and saying if you got a screw placed, we would do a check spin to make sure that they were correct. And so we were able then to compare the check spin to the virtual display to say, how are we doing in terms of our accuracy? And there's perhaps 2 degrees of variation. And I really like this figure 7 because that sort of starts to tell us what does 2 degrees of variation from what we think we're doing actually matter. So then we went on to do a prospectively video recorded in time screw placement. I've been told by a number of colleagues that, oh, navigation takes too long, it slows me down. And so, well, makes us pretty quick. We haven't had that be the case. And so we prospectively evaluated it to say, how long does it take us to place the screws? And this is a go-to-heck JBJS type of data table to show you that the screws were well distributed from T1 through the pelvis. And our average time for screw placement was on the order of 2 minutes and 13 seconds. But we also reported, so by coronal deformity, not by coronal deformity. And yeah, the numbers were big enough to show a difference, but is there a clinically important difference between 2 minutes and 2 minutes and 17 seconds? I don't know. Maybe the administrators in Seattle would think that would be important for OR time, but I think for most of us, probably clinically not. The pelvic screws took us a little longer, about 3.5 minutes. And here's the most important part of the study. So this is in a mature workflow, and that you can see our screw redirects were about 1%, our removals were about 1%, and we shortened it up about 0.25%. And one of the things that we've learned is that probably the threshold for change, if you're in the OR and you see what the CT looks like, I could have been bigger, I could have been longer, that one's just a tiny bit lateral, and let's just take 3 minutes to reposition, so let's go ahead and reposition. So how about deformity correction mechanics? It's been an evolving field. Harrington started with distraction rods and compression rods. Then Lukey introduced the concept of translation with his sublaminar wires. Then Cottrell and Dubussé introduced us to hook claws with derotation, which maybe derotated the spine versus translated it. Pedicle screws definitely perform derotation. Posterior column osteotomies, so often thought of as Smith-Peterson osteotomies, although probably more correctly described as Ponti in the thoracic spine, and then 3-column osteotomies with vertebral column resection as we got better at doing anterior work from a posterior approach. So just a representative Scheuermann's case, you can tell it's a little bit older because these are still actual film-based images. So here's the exposure, the osteotomies, and this was before I was doing navigation. Since we started doing navigation, we would place the screws first, osteotomy second. But prior to that, we would do our osteotomies, place our screws, and then I believe in a center out or centripetal correction mechanic, especially for kyphotic deformities, where we compress towards the apex and then get good results like this. Whereas in my training, if you had a 80-degree Scheuermann's kyphosis, you got a front back. And now we can do this pretty reliably from behind. And here's a more marked thoracal, lower thoracic thoracolumbar Scheuermann's or an atypical Scheuermann's. And again, all from the back with a pretty darn good correction. My practice has been one of revision surgeries. So this was a case done, I think, by David Bradford in the 1983-84 timeframe. And so the trick question, Jens, I don't know if you can ask any of the fellows if they know what those pedicle screws are.
Okay, here comes Dr. Kramer, a microphone, Dr. Kramer. What are the pedicle screws here on the left-hand side and in the second from right side? Microphone's coming to you, Mark.
I'm not sure. On the far left, are those Steffi plates?
Absolutely, very good. And unless you understand the instrumentation, trying to remove them is a real nightmare. If you understand the instrumentation, removing them is more
I
straightforward.
saw Nick pull Chat GPT out, so that doesn't count.
Dr. Randy Davis from Baltimore. Hi, Randy. Always great to have you with us. Also put it into the text chat. So this was cheating, but good cheating. And pattern recognition is important, and hardware recognition is super important so that you're mentally prepared. These can be slogs.
Yeah, and I think the original cold rolled CD may be even more challenging. And that's going to be a hard day. So the other piece that this case really brings home to me is the sagittal plane imbalance. And for the orthopedists in the audience, we look at the cup inclination there and how that guy is not dislocating. I do not know, but you can see that not only did we improve his sagittal alignment with a 3-column osteotomy, but we also put his acetabular component in a better position, and his functional level now 10 years out has been fully sustained, and he's quite delighted.
This is, can you go back again? This is as evocative a picture in terms of that all-important sagittal balance and the pelvic parameters as I've ever seen. That hip replacement in that second to right and then the far right, that is phenomenal. This is incredible. And you saved this guy's longevity of his hip replacement just with your spine surgery. Great picture. Thank you.
And one of the things I love about the newer imaging modalities is it allows us to see head to toe. And you could see that even then to stand up, he was bending his knees. And now we can see he can fully extend. And I think I've learned so much by looking at the lower extremities in conjunction with the spine, and that, gee, it's like it's all connected or something. Neuromonitoring. At the start of my career, we had SSEPs, but they were highly variable, institution to institution, whether or not they were reliable. And that I started by doing wake-up tests. And in fact, I helped design this drape, which had a clear plastic bottom, so that instead of asking the nurse, gee, are the feet moving? I could actually look at them and see. And that was how we really did neuromonitoring early in my career. But now the high quality of MEPs, TCMEPs, in addition to SSEPs, allow us to much more reliably determine and much more quickly determine if there's been some neurologic compromise. Sagittal alignment. Probably the biggest thing that we focused on in the last decade, maybe 2 decades, and that it starts with understanding pelvic incidence, and that we did a systematic review trying to say what is average pelvic incidence, and this is a literature-based review, and it very nicely clusters around 50 degrees, plus or minus 10 is a standard deviation, and so that helps us start to understand what is that range that exists within the population. And then this is the original description about how do we measure the pelvic incidence and what is it. And then Jean Dubasset taught us so much, and he just recently passed 2 days ago. And so the world has lost an absolute giant who inspired so many of us. But he described the cone of economy, and that when you're in the cone of economy, it doesn't take much energy to stand up. When you're out of the cone of economy, it takes a lot of work to stand up. And that really is the whole key to understanding sagittal alignment. Can we put the patient in a place where they don't need much muscular force to stand up? As we try to get better about alignment, this was one of my early past and patient-specific rods, trying to say, okay, did I get it just right? And that I've absolutely moved into the era of preoperative planning, determining a plan, taking intraoperative imaging and saying, okay, did we hit the target or not? And that goes back to my military background, that if you shoot at the right target, you got a good chance of hitting it. If you shoot at the wrong target, you're never going to hit it. And so just another example of a patient that had an unusual 12q deletion syndrome who we fixed, and I thought was going to be right, and I was wrong. And then we went back and revised her. And so even with preoperative planning, you don't always get it right. We're still learning about how to predict the response of the unfused or uninstrumented segments. So here is one of my not last cases, but near last cases. So a patient with a transitional segment, and Rod, I'd previously 10 years prior done a minimally invasive lateral interbody with perk screws, and she did well for 10 years, but her Scheuermann's got her, and she was perpetually hyperextending more things out. A colleague had done her anterior cervical discectomy, and we debated and debated, do we just do the lumbar spine and overcorrect it to match the thoracic spine, or do we do the whole shooting match? And I decided after multiple conversations with her to do the whole shooting match. So pelvic fixation has been really an interest of mine, in doing robust pelvic fixation to get a firm foundation and making sure that those screws are where we want them to be. And then she had a mid-thoracic disc herniation as well. We've gotten real comfortable at just coming far lateral and doing a transforaminal thoracic interbody fusion for these patients. And usually we only put in one cage, as opposed to routinely in the lumbar spine we do two. And that corrected that. And then building her alignment back up with the intradiscal work that I know you all are fans of. And then here's her on the table alignment, and that what she looked like. And so here was our plan. Here was our on the table alignment, and we were pretty darn close. And this was her 3-month follow-up, where she's finally turning the corner, because it was a big deal surgery. And so pre and post. And then a lot of my practice is revision work. And so this case had been done minimally invasive elsewhere. I'm not sure it was well thought out. And so the challenge of getting her corrected was a little more robust, but the preoperative planning helped. And now we're interested in the concept of, when we have the plan, how good are we at discerning, did we hit the target, did we overshoot, or did we undershoot? And what is our eye able to discern? And so that's work we have in progress right now, and love to collaborate with you guys further on this, because I find this absolutely intriguing. So what has changed in my career? Number one, better understanding of desired alignment goals. Now a low cognitive burden for placing anchors. And I think cognitive burden is something that we sort of, as surgeons, used to kind of ignore, but I think it's really important that when we're doing a PSO or taking scar down off of the cord or whatever, that we want to be at our best. And if you're totally exhausted just from putting screws in, you're probably not at your best. And so I think that that has been a help. We've gotten a lot better at releasing the spine from posterior to enhance correction. We have the ability to correct in multiple planes segmentally. We can better monitor the neurologic safety. We have improved intraoperative imaging. TXA has markedly decreased our blood loss and accelerated. We now have accelerated post-op recovery. So what I'm excited about, and what's still coming forward, is how do we minimize the collateral damage? How do we continue to improve our pre-op planning? And then how do we technically execute through training and technology to achieve that plan? And so I'd like to pause at this point, take questions, or we can move directly to the cases. So I'll stop sharing, Jens.
Excellent. So first of all, thank you for the shout out to Professor Jean Dubussy. He's been here multiple times. He's a I'm very proud of that, mentor of mine, and intrigued me into adolescence scoliosis surgery in my time at Texas Scottish Rite. As a German guy, I was considered the closest person to a French person to be his personal assistant for 6 months, and I have never looked back, and I cherish him and his wife on very dearly. So yes, game changer. Since we talked about the history of scoliosis, when we look at these old scoliosis fusions, you and I have had that same thing, and you and I are in this revision business. These fusions usually are massive, are profound. You have to have your hardware removal instruments out and get the metal osteotomes out which have been scored. How did they do it, and what are we doing wrong nowadays as we're using bone morphogenic protein, usually in an off-label fashion, and 4 rods? What did those masters do to get these fusions that made it so robust?
So John Moe was the king of the posterior, uninstrumented posterior spinal fusion. And he was absolutely meticulous. He would take the spinous processes off. He would he would take a Kapner gouge and feather the bone up, and then he would cut chunks of bone and put them in the facet joints. And then his dictum was every posterior ilium had enough bone graft available for a T4 to L4 fusion. And when he would harvest a bone graft from the posterior ilium, he would harvest a bone graft. And what was left was the inner table, and everything else was bone grafted. And then patients were kept recumbent or in a body cast for sometimes 6 months to 2 years in order to get the fusion solid. And that it was routine, at least in Minnesota for a while, that everybody at 6 months, you went back and explored the fusion and augmented it. And with that technique, the fusion masks were robust. And I think the other thing that happened was with the casting, they would get progressive slow correction. And so some of their corrections were pretty darn phenomenal, mainly from the Risser cast application. And I can tell you from patients who were treated by John Moe, they were not fans of the cast, and that sometimes they led to wound breakdowns and infections and, recumbency in a children's hospital for 6 months or a year.
Yeah, that was something I wanted to point out, the length of stay that I routinely ask these older fusion patients with Harrington rods and Edwards constructs, et cetera, how long were you in the hospital for? And it's literally what you just said, half a year. I think our administrators nowadays would not particularly like that. All patient satisfaction scores aside, just a thought. So a brilliant talk. Are we doing patients a disservice, just a big picture perspective again, with focusing so much on, you called it collateral damage, and I love that military term, by focusing so much on doing, quote, less invasive surgeries when we do compromise a bit inherently about alignment and certainly about bone healing. So the instrumentation precision is probably there now with navigation and experienced hands, certainly. But are we doing patients the true favor of realignment and giving them the best possible chance for fusion using this, quote, less invasive, our fellows called Wolverine technique?
Well, so I think the key lesson learned is that even in short segment lumbar degen fusions, you have to get the segmental sagittal alignment right. So whatever you got to do to get it right, do that, and that's easier to do the first time than it is as a revision. And I would say that it's not only our MIS colleagues who have left people flat, it's our open posterior colleagues who aren't deformity focused. And so that bad surgery can be done minimally invasively or maximally invasively. And that the trick is, how do you get it right? And I think we're still arguing a bit about what exactly is right. But I think we are really getting a lot closer. Our shot group is getting tighter. They're not all pinpoint bullseyes yet, but I think we have the potential to get there. And then if you can do that with less destruction, great. If you can't, then do what it takes to get it right. And that's the most important thing, and then deal with it and move on from there.
So I want to recognize for the public what does not need to be recognized. You were influential in the deformity world, and in your role as president of the SRS, also were finally and really well recognized for this, and you were one of the main people, and I hope you'll stay active in the SRS. But let me ask you a very critical question. Have we focused too much on alignments and less on the patient and their physiologic and psychosocial wherewithal to handle such surgeries, however you want to do them? The alignment versus the patient non-radiographic factors, let me just put it non-contentiously like that. Are we doing too many fusions, just coming blunt, straight out?
Yeah, so let's go back to Jean Dubussy, who would say, alignment is not balance. How many times did you hear him say that, Jens?
Yep.
But he was absolutely right, and that the issue is that when we think of alignment and the cone of economy, that's standing. Okay, great. Then when we think about balance, that's the ability to function in life in multiple positions. And what I struggle with is that while I think the alignment targets for standing is the right focus, we don't spend our whole life sitting. In fact, I mean, we don't spend our whole life standing. In fact, I look in the audience and all of you are sitting, and that is a change. And how do you compromise those two to enable function is a real question. And what I would say is fusion is an absolutely horrible solution to a problem. It just happens to be the best one that we have for now, and that the goal is to come up with non-fusion solutions that are durable and that are reliable. And we're making progress. I mean, cervical disc arthroplasty, I think, has made a profound difference. And I don't know that lumbar disc arthroplasty has had as strong an uptake, but the goal would be intradiscal regeneration, restoration of normal motion. But until we get there, we're still using a gas-powered engine that emits pollutants into the air.
Dr. Skuyan has a question.
Hey, David, this is a great talk that you gave, it's amazing to see how much in your career, I love that diagram that you showed with the thoracic. I remember when I was a resident that came out, and I literally had it in my coat pocket, and I would put it up, scotch tape it to the wall. And so, I think both you and Larry, it's remarkable when you look back on it, because I remember doing my first thoracic case, and it was very daunting, but it's incredible how much that's evolved. How much of your practice now would you say, I know you're retired, but were you using navigation for almost every case you did?
Yeah, the only time I wouldn't use navigation was when I was operating on 1- and 2-year-olds when the spinous process wasn't robust enough to hold a frame. The joke was that I was brushing my teeth with navigation. My dentist said I didn't do it very well, though.
So this is a terrific big picture review, and we'll all be treated to a life lessons learned part 2 shortly. Why don't we look at a couple of cases in the interest of time, and we'll start off with something non-contentious. We have Dr. Colin Gold, one of our fellows. He's close to you. He's from the University of Iowa, a neurosurgical colleague, and he has something that we see a lot of in our clinics. And Colin, why don't you take it from here?
All right.
Are we switching? Here we go. The switch has happened.
All right, great. So first patient, a mid-60s-year-old woman.
Oh, I'm not seeing your screen yet.
One second.
There we go.
I recognize the hard work by.
Good, okay. So yeah, mid-60s-year-old woman with years of low back pain, left leg pain, presents to clinic. She's had some mild relief of left leg pain after starting gabapentin recently, has tried injections in the past, has had temporary relief, and physical therapy has not completely relieved her symptoms. Past medical history is significant for asthma. She had a DEXA scan in 2024 and was negative 0.7 at the femoral neck. Past surgical history, L5S1 laminectomy in 2019 in an outside hospital, and she lives with her husband, is retired, and is a non-smoker. On physical exam, there's a lot of information to show the patient's neurologically intact, no sensory or motor deficits. So looking at her scoliosis films, these are the only ones that we had physical images of, so I couldn't compare over time, but 60-degree right thoracic curve, 60-degree left lumbar curve. Pelvic incidence is 69, lumbar lordosis is 33, and pelvic tilt is 36.
So if you go back, Dr. Pauly, I want to hear it from the president of the SRS Emeritus. I had to come up with that title. What should we use in discussing this curve, describing this curve in simple, basic nomenclature so that the public, so that primary care doctors, et cetera, can all wrap their heads around it? So just straight out the bat, how do we describe this curve best?
Yeah, so they're a combination of coronal and sagittal factors, right? And so Larry is promoting the adult idiopathic scoliosis nomenclature, and I think that will gain traction. For me, this is a double major curve pattern with relatively preserved sagittal alignment. But I would point out two things that get my interest immediately on this film. Number one is the limb length discrepancy. And so that's going to aggravate the lumbar curve. And then number two is that the sagittal alignment is pretty well preserved. Usually in patients like this, when they present with symptoms, they can have isolated foraminal stenosis, and it sounds like maybe that's what the initial thinking was for surgery. But I'm always worried they're going to get a lateral listhesis, either at L3 on L4 or L4 on L5, that contributes to it. And then the supine versus upright, there's a dynamic component to it as well. And that when you don't have old films, the thing that I try to dig into is ask the patients how much height they've lost. And if they've lost more than 2 inches, that probably exceeds measurement variability, and that suggests progression of the curve.
Those are awesome things. And if Ben would put the camera on me for a second, when you used your description of double major curve, yes, that's exactly what I still think, because that's truly what the general public and patients also kind of want to hear, the old King criteria, or however you want to call that. That still works, it's descriptive. And I love the basic compensated versus decompensated and sagittal alignment things. Those are the things that are meaningful. And I love the thought. And one of our ex-fellows, I think with your help, published that also, the loss and the restoration of vertical height with these adult deformities. Now here comes the next question. Maybe I'll do that now before Colin goes into greater nitty-gritty detail. And that is, when you see a patient like this, how long do you anticipate, barring any neurologic problems, and there are no neurologic problems as Dr. Gold showed, how long do you know and get to know such a patient before you pull the surgical trigger? Let's just assume purely structural, but no instability, no neurologic considerations.
Yeah, so there are two key questions that I ask. How long can you stand? How far can you walk? And when it's less than 5 minutes and less than half mile, they're usually probably ready to have something done. Then it becomes a discussion about what is that risk-benefit profile, what's associated with it, what can they expect to get out of it, and that there's this dance that we go through about not wanting to operate until they're sufficiently symptomatic, but as they get older and their bone gets softer, our ability to correct it gets worse. And so there is probably a sweet spot, and I don't know that we've fully defined that yet. But for me, it's how long can you stand, how far can you walk, and that really has helped. That's become compelling in terms of ability to discern who's ready for surgery.
And with apologies, Dr. Gold, follow-up question. This is, who should direct the non-surgical care? Do we have a vision of an integrated spine care center where we lateral the patient to a physiatry colleague, for instance, or should we be in charge of the non-surgical care and seek to optimize whatever is available there and direct traffic as a quarterback?
Yeah, so if you have a really great physiatrist, there are wonderful things that they can do. I would say the majority of physiatrists now have been trained to put needles in places, but less with musculoskeletal care. And so if you have an old school physiatrist like Heidi Prather, you're lucky and blessed and can do wonderful things. For me, it's finding the right physical therapist and having the physical therapist work with them. And I will offer Schroth or scoliosis specific exercises to this kind of patient. And for some of them, they get great response. And my answer to that is super, see you in a year. And if they don't get great response, then we talk about, okay, here are the other more invasive, more aggressive strategies going forward.
Great. And shout out to Dr. Ethel Lujan Medisa Madeira. It's always wonderful to hear words of encouragement. Thank you for being such a faithful, long-term participant in our series. Dr. Gold, I kept you waiting.
No problem. So this is her advanced imaging on the left, an MRI. And you can see significant foraminal stenosis, mostly on the left at 5.1, and then on the right, most other levels on the lower lumbar spine.
Yeah, and the concavity, she's going to have foraminal stenosis of every curve. It's just the way it's going to be.
And then so the CT scan shows the lumbar curve, and then also a little bit out of frame. There's a Bertolotti syndrome on the left side.
Can you show me that enough to see it? Does that scroll?
Oh, the CT scan's a static picture.
Okay, all right. Well, so can you classify by the Castelvi-Chan classification what type of Bertolotti's? Was it a 1, 2, probably not a 3?
I believe a 1.
Okay, so it's a close approach, but not a false joint?
Yeah.
Okay, all right. And the reason I bring that up is because the key to getting balance correction in these patients is almost always, what are you able to correct at the lumbosacral hemicurve? That then drives your ability and what you should aim for with the rest of the correction in order to try to get balanced alignment for the patient. And that you see a vacuum disc there, so that's probably some of the sequelae from the prior discectomy, and that I think that's going to move nicely. Our experience is we do this from behind, mainly because we don't have easy, excellent vascular surgery access surgeons to get us there. If we did, I would have no problems with A-lifts, but we do this with a bilateral T-lift posteriorly, and that we've been able to get about 68% correction of the lumbosacral hemicurve. The other thing that you notice is it's unclear if that's a bridging marginal osteophyte or not. It probably is. I still think that would be able to be cracked or loosened up with intradiscal work.
All right, so what did we do, and how do we proceed from there? Dr. Gold?
Yeah, no surgery yet for this one. The patient's going to follow up in 6 months. I don't think she's at that threshold yet of can't stand for 5 minutes and can't walk for half a mile.
Dr.
So
Skurian,
she's
you're
going to continue PT.
a little shout out for our lateral access course. So that was a visionary meeting with Dr. Spimenta, Bill Taylor, Juan Uribe, and yourself. And I get to speak at that as a non-lateral surgeon. But Rod, what are you going to do here for this patient?
I mean, I think the
she
thing
crosses?
was, David, the reason I wanted to show you this is, can you go back to the standing x-rays? Is it, I think I've seen her now for almost a year, so I don't feel like I know her that well. But she's pretty debilitated, and I think she was pretty frustrated that I think I just said, look, you're not ready for surgery yet. But the reason why I wanted to present this case, David, is that let's say if you were going to operate on her, having your years of experience and all the different approaches that you've done, what would be the definitive surgery for someone like this? Because I think, I sort of have my views, but I wanted to get your views on, how high do you go? Do you go from the front? Do you do all this from the back? And then what do you do for the pelvis? Because she's so balanced right now.
Right. So in the days of Harrington rods, this was easy. This was a T4 to L4 $ rod. It crossed the S curve. It helped keep it balanced. Wasn't great stable fixation, but that's how we did it. And so for me, this would be an upper thoracic to pelvis. I do this again, as I said, all from behind because we didn't have good access surgeon accessibility. And that I would do aggressive work at the lumbosacral junction at the hemicurve with posterior interbodies, and then balance correction would be the key here. And I would not be offended by putting a rod that crossed this curve pattern and then you pull both sides to it. That's still something that occasionally has a role. Been unusual for us to do it in the past, but you're absolutely right. And that the other challenge with the balance in her, the unresolved topic in my mind today is, do you fuse her perpendicular to the floor or perpendicular to the pelvis? And Larry and I disagree on this a little bit. Larry wants to fuse them perpendicular to the floor, and I understand that. But then when they sit, if they're sitting for a long time, they're tilted off, right? And my tendency has been more to go perpendicular to the pelvis and give them a shoe lift. And when they get up at night to go to use the toilet, they don't like that as much, but
Great
that's
point.
sort of been my philosophical approach. And for me, this would be upper thoracic to pelvis, and I would do 4 rods across the lumbosacral junction.
And quick question, and in this case, it's probably not so applicable, but upper versus lower thoracic spine, and you and I have debated in several settings the question of adjacent segment failure, and one of the most frustrating things there is. But if in doubt, and again, not applicable in this case, would you, in a postmenopausal female patient especially, maybe some osteopenia, go to the upper or lower thoracic spine from a functional perspective? What's the better answer there?
Yeah, so at least the data that seems to currently exist suggests that PJK rates are lower with upper thoracic versus lower thoracic. Given the magnitude of that curve in the thoracic spine, I would include both curves. And so I'm probably T4 or T5 on her.
Great. Well, thank you for that presentation, Dr. Gold, and we'll switch to Dr. Mark Kramer, who is a neurosurgical colleague from the University of Wisconsin. So again,
My
Midwestern
neighborhood.
common sense and practical purpose. Dr. Mark Kramer is a neurosurgical colleague from the vaunted neurosurgery program there, and he has 2 cases, and we'll go through those a little bit faster to make room for Dr. Minasali.
Will do. Okay, so the first case is a challenging case we just did last week. It's a 30-year-old woman. She has dwarfism. She presented with bilateral leg weakness. Her story is that she was involved in a motor vehicle accident about 10 months ago, and within about 4 or 5 months after the accident, she'd been developing some weakness. And you can see she kind of gradually became more reliant on ambulatory aids. She was using a cane or walker in the fall, and then around the holidays, essentially became wheelchair dependent. And she was wheelchair dependent when she presented to us. No other previous surgeries on her back. She did have a Chiari decompression in the past. So you can see her height, 3'10", 60 kilograms. She's quite profoundly weak in the left leg, more so than the right. Basically a complete foot drop on the left side. And she's got some pathologic reflexes and sustained clonus, again, more so on that left side. So here's her imaging. You can see that she's got a compression deformity at L1. And her overall balance, she's tilted, she's a smaller person. And not a horrible coronal balance.
So Mark, were there any pre-accident images or just the post-accident images?
Post-accident images,
Okay.
we don't have any.
I was going to say that the achondroplast, it's not uncommon to see wedging at the thoracolumbar junction. So
Good question. Unclear
Her
if
mom
this.
had actually, I interviewed her mom on that, and she couldn't find the images, but she told me that she was aware from a previous chest x-ray that she had this wedging of a vertebra as a young girl. So I don't have any radiographic evidence to show, but the mother was not surprised when I talked to her about that wedged vertebra.
yeah,
And
that morphology looks more like achondroplasia than trauma to me. And the way I would put it together is she was at the edge of the cliff and then the accident pushed her over.
That's a good point. Yeah, like I said, I don't have any previous imaging that I could review. And again, the imaging that she came in with us was this MRI, and then of course these X-rays. And you can see based on the MRI here, sagittal T2, and then a couple selected cuts through disc spaces at L1-2 and L2-3, very severe stenosis. So we elected to perform a myelogram preoperatively. It shows similar findings. Good to know that her Chiari decompression is robust. She had a C1 laminectomy there, it appears, as well. And although this cut is not great through the thoracic spine, there is no significant stenosis in the upper thoracic spine.
So you talked about pelvic alignment. Does this, oh, that's a nice summary slide, Mark. Does pelvic alignment matter in a patient with this? I mean, this is a horizontal sacrum, basically, and a hyperlordotic lumbar spine. I forgot what the degrees are. And then she has this, I think we measured 45 degrees or 49 degrees focal kyphosis around her L1 vertebra. So Do alignment parameters matter here? And we have obviously a neurologic crisis, which is subacute now, percolating for 6 to 8 months. How do we address this patient's neurologic needs and alignment considerations?
Yeah, so so the dwarf community has different alignment than the rest of the population. And the achondroplasts are probably the best studied, and that this horizontal sacrum is not atypical, and the anteverted pelvis is not atypical. And it's also not atypical for them to have multi-level horrible spinal stenosis. And so I'm impressed that she's really just focal compression at the deformed vertebral level. And the rest of it is not so bad in terms of the way that achondroplasts look, at least in my experience. And so to me, this says correct that focal deformity at so relieve the neurologic compression and correct that focal deformity, and you may be able to get away with short segment correction. And the interesting piece that we don't know is how will the thoracic spine respond, that she is probably hyperextending her thoracic spine in order to maintain upright posture, and that Kristen Jones, one of my former partners, would get seated flexion lateral thoracic spine images to see how much thoracic kyphosis could potentially restore spontaneously. I don't know how predictive that is, but it's been an interesting thought process to go through. And so my thoughts on this are decompress at the compressed levels. Then the question is, do you do a corpectomy or do you do intradiscal work here? The intradiscal work would have to be so aggressive, and the morphology of that vertebra looks a little less favorable to it. And so to me, this is probably a posterior VCR, but it's probably a VCR, whether you do it posterior or lateral or whatever. And then the question is 1 or 2 levels above and below for the segmental instrumentation.
All right, great discussion. And again, in interest of time, Mark, take us forwards.
Yeah, so you hit the question that we asked initially as well, corpectomy or IDOs. We elected for IDOs.
That's beautiful.
We felt that, and as you said, aggressive IDOs to kind of get the correction. We felt that we could kind of pivot off of that vertebral body and improve the correction by doing kind of above and below IDOs and kind of pivoting off of that vertebra to get the correction. So this is we don't have any standing films yet for her, but this is our post-op CT. You can see we got a nice decompression.
So let me ask one pointing question, if you can go back through that. It looks to me like there's almost a little posterior translation of the caudal aspect of that anomalous segment. And that would worry me. I can't tell if you've done a laminectomy there or not, but so this is a beautiful result. And if she's neurologically improving, you can't ask for more than that. It's just as I would critique myself, I would say, I don't like that posterior translation component of the caudal aspect of the wedge vertebra.
Point well taken. Again, we could run our rectangular and curved neural probes effortlessly around the dural tube. So yes, radiographically, I agree. Clinically, she's actually done quite well, and she feels improved. We're sending her to rehab hopefully today. But yeah, there's clearly some component, and of course the decompression goes above and below that in our standard fashion. So there's at least one segment above, one segment below, full decompression. I think you can see it on that CT cut. Yeah.
No, that's really nice realignment. And it looked to me like there was change from the upright film to the supine radiograph, and indicating a dynamic component to the neural compromise. And so even stabilizing probably helps, but stabilizing and decompressing and correcting deformity, which you have clearly done, definitely improves the environment for the neural elements.
Okay, thanks for your comments. And then Mark, go to case number 2.
All right, so case 2 is a case from about 18 months ago. 70-year-old gentleman, back pain, leg pain. He had this previous fusion. You can see it was done from the front. They did some A-lifts, I believe. I don't have access to the reports, but
Yeah, it looks like femoral ring allograft.
so 4 to S1 fusion, intractable back pain, unable to stand up straight, kyphotic posture, some history of smoking in the past but not current, and otherwise pretty hardworking dude. He's lives on the eastern side of the state, still owns and operates a cattle farm. Some mild weakness in primarily EHL and ankle plantar flexion. Otherwise, no pathologic reflexes. Here's his standing films. I can see very significantly positive SVA, almost 20 centimeters. Coronal balance fairly good. I noted some of his parameters here. His pelvic index is about 70 degrees, and his lumbar lordosis is -4 degrees. Thoracic kyphosis, 24 degrees. Here's his MRI that he presented with. You can see above the fusion, he's got real severe stenosis at the selected cut at L3-4. We, again, elected to perform a myelogram in this case. You can see that at least above this area, no significant stenosis in the thoracic spine, but there is real severe stenosis at that proximal junction at L3-4. And there was also a nuclear medicine study performed as well, demonstrating some increased uptake at that L3 region, which actually is consistent with kind of a chronic compression deformity. So in summary, 70-year-old gentleman, kyphotic posture, previous fusion, and he's unable to stand up straight.
I'm shocked the pain pump didn't solve all problems.
Same here. The only thing that was missing was the dorsal column stimulator. I mean, the dual strategy is becoming increasingly common in my practice, and you and I are very similarly sarcastic about these applications, and I'm still wondering whether there's a causal connection in decompensating patients in their adult spinal deformities with these well-intended devices. So
yeah, so let me just run through my thoughts here, Jens. So number one, even though they did an A-lift, they didn't restore adequate L4 to S1 lordosis. So what would you think L4 to S1 lordosis ought to be?
Ought to be 44 degrees or so.
Yeah, so somewhere in the 35 to 40 degree range. And he's what, I don't know, 15. And that's because the cage is settled into the vertebral bodies. Okay. He's got a high PI, so where he needs his lordosis is in the upper arc as well as the lower arc. And so for me, the advantage is the supine film shows he's got a nice vacuum phenomenon at the 3-4 disc. And so I'm really going to push to get as much lordosis at that segment as I can. And I'm going to do the same thing at the segment above. And then I'm going to think about where I take this up to. And I'm thinking probably lower thoracic, but I'm not convinced on that. And then the other piece in the host component of things, the highest positive predictor of return to work is a self-employed farmer.
That's my experience as well, coming from Wisconsin.
Yeah, they are going back to work. And, you know, I remember this 80-year-old guy came back to see me for a 6-week post-op visit. And he said, "Can I get back on the tractor?" And his wife looked at me and said, "He already did." So,
by the way, it doesn't matter if you're neurosurgical or orthopedic surgery educated. Farming background makes you a superstar regardless of your specialty. There's something special to that discipline and exposure to problem solving. Yes, I agree. So, Mark, you heard what Dr. Pauly said.
Yeah, so he's now about a year and a half out, and he's doing phenomenal. He actually saw him in clinic this last week. Here's his reconstruction, T8 to pelvis. We did a laminectomy, of course, over the area of stenosis. I performed exactly the plan that you just mentioned. So 3-4 and 2-3, the level of severe stenosis, we did an IDO, and then the level above, we're able to obtain a really nice correction in quad rod construct. And as I mentioned, he's He's at this point kind of retired. He's in his 70s, but he's still a hardworking guy, and he's still getting around great. He did have a prolonged recovery. He was in a skilled nursing facility for some period of time after the operation, but it took him about 3 to 6 months before he's kind of back and doing well.
Yeah, my biggest battle with him was he had been successfully conditioned to tolerate large doses of opiates by various well-meaning, I was dripping into a Freudian slip here for a second, well-meaning pain specialists, I'm sure. And so we had a pretty long prehab period also, and the post-op period was frustrating in that regard because there was a high degree of opiate tolerance, but he's extremely happy. He's off all things. He can't wait to get his wonderful pump explanted, and he's actually functionally doing remarkably well. So very gratifying to see, but yeah, proximal junction, do hooks help? Do cables help? Do bands help?
I think the thing that helps the best is getting the sagittal alignment right. And your sagittal alignment there looks very good. And probably the T4L1 PA is probably the best metric that we have. And I thought that looked, as best as I could eyeball it, those look pretty close. And so I think you got that right. And then there is not compelling data for or against hooks or tethers at this point. Do we use them? Yes. Do they make a difference? I don't know.
Perfect. Are you willing to look at one more case, Dr. Paul?
Yep.
So we'll fast forward through this, and Dr. Nick Minisali, thank you, Dr. Kramer, nicely done. Dr. Nick Minisali is not wearing Philadelphia Eagles green anymore. He is from the Rothman Healthcare System, so strong Philly background, going back to New Jersey, orthopedic colleague. Dr. Nick Minisali, show your case to Dr. Pauly.
Sure, thank you. So like we said, we'll get right to it. It's a 60-year-old male with a prior T9 Asia A spinal cord injury due to a motor vehicle accident back in 2001. And he had a T4 to L2 posterior instrumented fusion with rod and hook construct, not a Harrington rod. His chief complaint of recent was clicking sensation in the spine with motion and then some spasticity in the lower extremities. Very, very independent patient, self-transfers for wheelchair, still drives a modified Subaru. He does have neurogenic bowel and bladder, but he self-catheterizes. Not a current smoker, single, low BMI, and fully intact in the upper extremities.
And shows the images, yeah.
So initial clinic visit back in 2020 demonstrating the prior construct intact. Evidence of some early Charcot arthropathy at L2-3 more so than 3-4, evidenced by the pseudo joint formation, gas in the disc space, and significant osteophyte formation. However, further follow-up, close follow-up over the past several years, this is a more recent CT demonstrating significant dissociation of L2-3, worsening Charcot arthropathy.
So Jean-Martin Charcot, so thoughts. So first of all, put your hat on as a trauma surgeon and with the insights and wisdom of a deformity surgeon. We are many times told, oh, if you have a trauma injury and you want to just fix it from the back, do multiple levels, you can't harm the patient. Knowing what you know now, is that bad advice?
Well, so this looked like it is, my guess is this is one of the early version TSRH constructs.
Yep, exactly.
And you know, if you're doing only hooks, then you probably do need to be longer than if you're doing screws. And what I would say now is I would do 2 levels above screws, 2 levels below screws. I think there were a couple of things in the history that were probably more important. Where I see this is the more active the paraplegic is, the more likely this is to happen. And that I've got almost the same story in another patient who came in to me and he'd lost about 10 inches of height and his interscapular spine was touching his sacrum. And it's like, okay, that's not good. And his blood pressure control had been bad, and it was because of exactly this. And then you hope you see them before some interventionalist is aspirating that to make sure it's not an infection, because they do enough aspirations and eventually it becomes an infection. And then the other piece is I always worried about, how am I going to find the neural elements there and not mess them up? And usually when it gets to this point, they've transected them. And so this is the one where you let the junior resident put in the pedicle screws and that they're not likely to hurt something. But
So, yeah, the key thing surgically here, so first of all, I think you and I agree, but why would you do surgery? This patient is paraplegic. I've actually heard this argument made by several people who I kind of respect, and that is, this is a motion segment. Why would you take that away from these patients? So this is this is an Asia A patient with a neurologic level around T8-ish. You see the cerclage cable up there. So why would we fix this and fuse
I
this?
think the concept of accelerated rehab is valid, and that if they are, I mean, the question is, do you just say become a total nihilist and just let them fling themselves around without stability versus giving them some stability in a mid-thoracic spine? Boy, to me, I'd love to fix that, just two above and two below, and they still have the entirety of the lumbar spine, but at least my understanding, I don't have as much experience as like say Alex Vaccaro does from the Philadelphia trauma experiences, that if you have someone who is very active afterwards, it's only a question of when they're going to develop their Charcot. And that
So we'd go to the pelvis, or would you try to preserve like
yeah,
the
so I think that the answer is that this is a long-term sequelae of a horrible problem, and that I would fix them short initially, get them going as long as they can, and then when they start hearing the clicking or losing height, then look at what's going on and then extend it down, and then ultimately you're going to go to the pelvis, and then the problem is going to be ischial tuberosity, skin breakdown, and so.
Yeah, so just interrupting you, Dr. Randy Davis is always very insightful. He identified, and I totally concur, patients with untreated Charcot arthropathies develop significant autonomic dysreflexia. We had a great journal club last Friday. We actually showed this case here, full disclosure, but our fellows, 4 of our fellows presented very good current insights into not just Charcot arthropathies, but ascending syrinx formation, neuromodulation, and I forgot what the fourth element was. Spasticity, of course, spasticity. This patient had spasticity, by the way, he had an intact neural tube. I want to recognize the eminent work that you and your team at the University of Minnesota have done for pelvic fixation. Thank you so much. And this is where we're heading to the case resolution.
Yes, so because our patient demonstrated no signs of infection pre-op, no decubiti, normal lab workup pre-op, and intra-op looked like there was no concern for infection, we went with a single stage posterior hardware removal T7 to L2, complete corpectomy at L2 with partial corpectomies L1 and 3, with cage placement with BMP, and then posterior instrumented fusion T8 to pelvis with quad rod and dual iliac fixation bilaterally. And then still did irrigation, still took cultures and pathology, which were negative. And so this patient was discharged on post-op day 8 to acute rehab.
So question to you, so you showed some very nice, very large bore pelvic fixation devices. My question to you is how much hardware do we really want to put into that lumbopelvic junction? And are we destroying valuable bone in case that these loosen and fail? So is this enough what I did here, 8.5 paired, meaning stacked iliac screws, or should I have gone for like 10.5 large bore devices?
Yeah, so my bias, Jens, is to build it as robust as I can the first time around. And I think that the revision rate won't be 0. Nothing we do, the revision rate is going to be 0. But it's going to, I think, be lower. And that the other piece especially in this scenario, is the guy's going to have to use a slider board for a while instead of flinging himself. And they don't like that because it really takes away some of their independence. And so I think getting it to heal is part of what we're going after, but I want it robust enough that they're not going to break it.
And again, you've done so much to educate us about lumbopelvic fixation and pelvic fixation specifically, and SI joint fixation. So thank you for this eminent work. Segue to introduce the final talk of Dr. Paulies. So again, huge honor to celebrate your retirement, and hopefully you'll stay engaged with us as the future goes on with your wisdom. And I want to just again tell those who came late, Dr. Pauly does not need an introduction, but he is Professor Chief of Spine Surgery in the Department of Orthopedic Surgery at the University of Minnesota, holder of the, or immediate past holder of the James W. Ogilvie Chair and the Catherine Mills Davis Land Grant Chair in Biomechanical Engineering, past president of SRS and a number of other major spine organizations worldwide, recognized for his efforts around adult spinal deformity care and sacroiliac fixation, game changer. And we thought it would be a fantastic way to honor him, to ask him to speak about two things. You saw a great lecture on highlights of technological developments in spine. Now comes the more metaphysical aspect of lessons learned. Thank you, Dr. Pauly, for being here today.
All right, give me just 1 second to get the right.
There he is.
All right. So perhaps this is more of a fireside chat than it is a lecture, but it's sort of, you know, if I'm talking to younger colleagues and how to help them get there faster than I did, these are the lessons that I'd want to share. So this is my practice, or at least what was my practice, primary adult deformity, just like the case that you showed. Probably should have gone up 1 or 2 levels higher. Revision surgery for flat back keeps us busy. This patient had had a neuroblastoma, multiple prior fusions, couldn't stand up straight, bad skin, revision work. Then this one we talked about already, neuromuscular scoliosis. This young man lost the genetic lottery who had both Duchenne's and Marfan's, never seen that before. And then Charcot spine. And so, no, I didn't know you were going to show me a Charcot case, but this is someone who had a vascular cord injury at birth, had 2 prior surgeries, and then presented to me like this. And this was how I went after it. And so there's your answer from my thought process. Every once in a while, I got to sneak in a primary pediatric congenital deformity. I absolutely love these because this was the one time I could cure scoliosis, was to take out the hemivertebra. It's also when I couldn't navigate typically because the spinous processes wouldn't hold a reference frame. And then, you know, this was the case I told you about that I didn't get right the first time and I had to work at to get right the second time. So I love this slide. Proper prior planning prevents piss poor performance. I think Jens just understood why I like this slide. And then the key advice I give to my residents and fellows is when you're looking for a job, question number 1, do you trust your partners? If you don't trust your partners, nothing else matters. Number 2, spend less than you make, whatever that is. And if you do those 2 things, that's really led, I think, to greater job satisfaction than about any other parameters I could come up with. In terms of care of patients, studying and examining each patient to understand where their deformity is, what their problem is, and what are all the alternatives for fixing it, and decide what are you capable of doing or not doing. Because if, you know, these guys can do amazing things, and Jens and Rod do amazing things. You may or may not be able to do those same amazing things. And if you tackle something, trying to do something that you've seen done but can't do, boy, there's probably no more uncomfortable place in the world than where you are in the OR at that moment. Accumulated experience matters. So this is Larry Linke's office. Those are 3D models from the last 5 years of patients that he has corrected. So we've become fans of the Complex Spine Conference. And so that we meet once a month and go through the patients and their problem, their surgical problem, their overall health status, and are they ready for surgery? And that 10 out of 55 for a 6-month period needed work on bone health, and 29 out of 55 needed other things. And that we do this with our anesthesiologists, and it's resulted in a rate of about 0 day of surgery cancellation. And that has been a real benefit for us to work with our colleagues and say, what do you want? And get that work up before they're in the pre-op area, resulting in being able to go forward and do the work as planned. So whenever you train, you are going to learn the current state of the art. However, the state of the art is going to evolve. And the question then is, how do you adapt to the new state of the art? And for me, that experience in the mid-90s was visiting Jürgen Harms. And he had a profound impact on me. I was well-trained, and what I did worked for, I don't know, 85% of the patients, but it didn't work for all of them. And it's like, how do I incrementally get better? So I saw Harms do a TLIF, and it hadn't been named a TLIF yet. And I went back to the Gasthaus, and I tried to draw a picture of each step of the procedure to try to understand it precisely, to say, can I repeat this? And I had the privilege of spending a week with Harry Schuffelbarger, one of the most efficient surgeons I've ever seen. And that taking apart what they did, understanding how they did it, and then saying, okay, what are the critical elements, then perhaps allows you to try to replicate that in your hands. And I think that today, with the videos and everything else, it's like, oh, I saw this reported, I saw this on a video, I think I can go do it. Well, I've spent hundreds or probably thousands of hours in anatomy labs practicing before I ever tried to do it in a patient. And that really, really helped me. Rigorously critique your own results. If you don't, somebody else will, for sure. And so be your own worst critic and always try to get better and say, what can I do to improve? And so these are just examples of, the patient-specific preoperative planning, and then comparing the intraoperative execution to the preoperative planning. So if you're a spine surgeon, there's a moderately high chance that you're going to be in a medical malpractice suit somewhere in your career. If you're lucky, it'll only be 1 or 2. And my lesson learned from one that I went through is that I told this person who was a nurse that I had a 75% chance of helping them. And what I don't think I appreciated is patient bias. When you tell them 75% chance you're going to help them, I've learned that if you tell them, that means 25% of the time you're not going to be better, and some of those patients are going to be worse. And better means better, not perfect. And I don't think we can hammer that home enough, because if we don't meet our patients' expectations, then they're asking all these questions, going after all of these things. And so if our expectations are here and theirs are here, we're going to be happy. If it's reversed, we're not going to be happy, and they're not going to be happy. So I have 2 rules about surgery. Number 1, the patient has to be able to live through the surgery to need the surgery. And number 2, never put anything in that you're not prepared to take out. And I don't care whether that's sacroplasty or whatever, that almost inevitably, we're not curing spine problems, we're managing them. And that anything that you put in has the potential to get infected or come apart, and it might need to come out. So think about the next step in care. Even if everything you do goes well and is right and works for 10 years down the road, someone else may have to deal with it. Continue to learn. So I really like the International Spine Deformity Symposium. It's almost as good as the Seattle Science Foundation programs. Come on, Jens, that should at least get a smile from you and Rod. But go to meetings that cover topics that deal with the patients that you deal with. Hear what they're thinking, hear what they're saying. You don't have to be the first, but you probably don't want to be the last to adopt new techniques. And so continue to invest in yourself and learn from others. Question what they're saying, but learn what you can from them. Jim Ogilvy, who's pictured here, was my primary teacher and mentor. And he said to me, if you want to be happy in your life, don't operate as Charmans. And I was thinking, why are you saying that? It's a single plane deformity, relatively healthy people. So I studied it, worked on it. I got to meet Alberto Ponte here in Bologna, Italy. had some breakthroughs, thought I understood it. And, you get this kind of a case who presented to me after being followed elsewhere with pretty significant progression. And so my thoughts about Shoreman's, we talk about cantilever correction. Like, yeah, that I think leads to junctional issues. I like apically directed correction, where we're translating the spine to the rod. And so this person clearly met criteria for surgical intervention, and that a lot of intradiscal work there, Jens, even in the thoracic spine. And I got her a lot better. I don't know that it was perfect, and I struggled with why didn't I like the correction as much, and not sure I ever fully answered it. But she is happy. I'm okay with it, but it, in my mind, perhaps could have been better. Maybe I should have gone up a little more cephalad. Then Larry Linke's strategy for these bigger curves, so this is a 90-degree curve, has been an apical VCR. And so I did that in this guy, and the x-ray looks better. Is that the right answer always? Well, I think it varies from patient to patient, but that we're continuing to evolve and get better. And again, in my training, this would have been a front back, and this would have been a hard one to do in the front because it's high thoracic and it's difficult to get up that high to get good discectomies and anterior releases. Choose to take on some difficult things in your life. They make a difference. This was the SRS group going to the FDA when we were trying to get approval or on-label approval for pediatric pedicle screws. And this is follow-up work at the FDA, and that collaborating with them has led to some positive improvements. I want to spend a little time on this. I had the privilege of getting to know Colin Powell fairly well when I was at Walter Reed. I took care of his son for a decade. And that his 13 lessons, I think, are just absolutely key. Oops, sorry about that. It's not as bad as you think, and it'll look better in the morning. Number 2 really resonates with me. I can feel myself boil up with rage when something happens or something goes on. And sometimes I can let the wave wash over me, but I sometimes need to blow up and then get over it real quick. Avoid having your ego so close to your position that when you're no longer chief or whatever, that your ego goes away. Most things can be done. It's just how hard do you have to work at it and how do you have to do it? Be careful what you ask for, you may get it. Don't let adverse facts stand in the way of a good decision. And so, we're rarely making perfect decisions. We're balancing trying to do what's best given a tough set of circumstances. And you can't make someone else's choices and don't necessarily let them make yours. Check small things. Oh, I'm sorry. I've got something that's in the way and I can't read number 9 to you. Can you read that out?
Oh, that's all sure. Which one?
I can't read number 9.
Share credit.
Yes.
Yes.
So I love the phrase, praise publicly, condemn privately. And so in leadership positions, any chance you get to praise someone in public, do that. If you have to correct them for whatever reason, that should be done in private. I love 10, remain calm and be kind. Kindness almost costs us nothing, but have vision for excellence and be demanding and expect that excellence. And don't take counsel or fear from your naysayers, and perpetual optimism is a force multiplier. So you're going to always be building or rebuilding your team, and it's always worth the effort. What is your team? Your team are your partners, your clinic staff, your OR staff, the radiology techs. Radiology techs come in 2 flavors. Have I used this one with you guys before? They're either Einstein or Frankenstein.
No, that's new.
And then your front desk people, whoever's answering the telephone, that's the first touch point for people trying to reach you. Are they any good? Are they kind? Your secretary, boy, does that help. Your research team, your institution, and the human resources people, you got to work with them. The finance team, supply chain, vendor reps, floor staff, everybody who has any contact with your patient is a part of your team, whether you see them or not. And anything you can do to build the loyalty and enthusiasm in that team makes a difference. So when I got to Walter Reed, I didn't have much rank or authority. So I had to find a way to induce people to want to work with me. So I got these Walter Reed Spine Team t-shirts made up. And this is Tracy Goldner Rademacher. This is 25 years later. She still has her team t-shirt. So when the tech was good enough, I would have a ceremony and present the t-shirt to them. And you think that matters? Oh, yes, it does. So my clinic team, can't do much without them. And I make it a point to do holiday celebrations with them out of my pocket, best investment I can make. Here is an absolute key lesson for more junior physicians. Choosing to enjoy your patients in clinic makes life so much more bearable. It took me a long time to get to this point of choosing to enjoy spending time with them. If clinic is just, oh, what's my batting average for recommending surgery, then it's drudgery. But if you recognize these people want to see you, they want to hear what you have to say, it's a dopamine hit every time you walk in the room, and choose to enjoy that, you'll be happier, they'll be happier, and your life will be better. Mentors, mentees, all matter. And to me, the greatest compliment to the teacher is to have the student exceed the teacher. And I've had multiple opportunities of that, and I am so proud of those individuals. Learn from the giants in the past. As we said, Jean Dubasset, and then Steve Andra was my partner, neurosurgery partner at Walter Reed when I first got there, and we shared a lot of growth together. But Jean Dubasset, what tremendous insight. His cone of economy. I love this shot of Jean-Charles Louek, and perhaps the cone of economy is a little smaller than we originally thought. And if you're the smartest person in the room, you're in the wrong room. You want to hang out with people who are smarter than you because they're going to make you better. Honor the ones who put up with you. Find excuses to celebrate. I love this line, which I sort of attribute to Chris Shaffrey. Pessimists see the glass half empty. Optimists are already opening another bottle. And yes, that's my wine cellar. Wow. Invite people you don't always agree with. So this is when Pierre Rousselet came to visit us, and I didn't really understand some of what he was saying. But boy, the opportunity to share with him and to learn from him was spectacular. And the opportunity to share that with others so that they get a chance to say, oh yeah, I met Dr. Rousselet and we listened to him. And then these were the SRS traveling fellows, and we went to a lab in the Minneapolis area. And so I don't care who you are, the opportunities to work in the lab still allows you to grow. Have some fun. The Twins didn't win that night. I'm sorry. I don't think we were playing Seattle, but and then visit others and give your best talk and listen to their critiques, because their critiques will help make you better. The chance to visit other esteemed places with friends and to share and to grow jointly. Sometimes the trips are long, but many times they're worth it. And so this is in Istanbul with Azmi Hamzoglu, the Nordic Spine Deformity Society in Copenhagen. And you think what we do is hard. Well, you all have some people at Fort Lewis who are pretty tough customers, the Army Rangers. So this is my Army Ranger class in 1979. I doubt any of you can pick me out, but that's me. That's the hardest thing I ever did in my life. I love this Japanese philosophy piece. Do what you love, do what you're good at, do what the world needs, and do what you can be paid for. And we are fortunate to get to do that. It goes fast. And this is my father, who was also a West Pointer, who was born on Veterans Day and died on the 4th of July. And so what I would say to you is, as I ride off into the sunset, do great things. And thank you, Seattle Science Foundation, for being a part of my journey.
What a wonderful lecture. May I ask everybody in the room to stand up? Just, and we've never done that before, but we'll all stand. You can't see the room probably, but we want to just thank you. I do want to recognize your patriotism and your unwavering dedication towards improving those around you. And that includes myself as a grateful beneficiary of your insights and your camaraderie, especially in hard times, and that shall never be forgotten. And I hope that the sunset is actually not there yet. It's just a different phase of maybe past the zenith of the sun, but I hope that there's a long and productive ongoing interaction and a chance for you to visit here also and replenish, shine that star of yours. It's right in the front, as you see, in a long hallway of a lot of cool people, but it's such a privilege and honor to have you. Rod, any thoughts from your end?
That was awesome, David, and hopefully we get to see you more now that you have more free time. So it's been really amazing, partnership, friendship, and hope to see you in Seattle more.
As long as Jens will take me to Canlis.
So
Dr.
it is,
Polly,
yeah.
I just wanted to ask you one question. This is Nick, one of the fellows. Thank you so much for your talk. Really appreciate your time and insight. What would you say is your best recommendation for, fellows like us coming out of really well-trained, fantastic institutions? When should you start electively taking on those really complex cases? And I've asked Dr. Chapman and my other mentors here, but I'd love to hear your take on it.
Yeah, so my course was probably not typical. So I went from Walter Reed to Minnesota to do my fellowship and came back to Walter Reed as the chief of spine surgery and the only orthopedic spine surgeon. My colleague, Steve Andro, was there in neurosurgery. And I had a list of 88 patients who needed surgery because it was a long wait time to get in. And I didn't get to start slow. And so I had to grow up fast. What I would recommend if you have the choice is to do the things that you feel that you're ready to do and progressively work up to it. Have a low threshold that if you have a senior partner, say, maybe it would be better if Dr. Smith did this and I'll do it with him and I'll hold hooks for him. I'll do whatever. And I'll be glad to see you back and follow up and I'll take care of you and I'll take care of anything that needs to be done. And when you do that, you both build your experience and your patient confidence in you. There is going to be the middle of the night when you're going to get called for an acute something that has happened that you're going to have to do it and you're going to have to do it by yourself. And that's going to be hard. And it will be a growth opportunity. And so if you can work your way into it, do that, but don't feel like you have to do every case. If there are cases that could be better done by someone else, I've never had a patient complain to me when I said, what you need is this, and Dr. X does this so much better than I do. I think you ought to have Dr. X do it. And that if you need something else done down the road, I'm happy to take care of it. I'm happy to see you back. And that really builds an excellent reputation for yourself. And if it's beyond what you think you can do, don't do it. Have someone else do it. The other thing that's different is right now you're in an environment where you've got a well-oiled machine. You got good techs, you got good nursing staff, everybody's used to it. And it will take you twice as long to do a lumbar discectomy when you are on your own than it does now. And just expect that. And so work your way into it. But that's a hard thing, and it really depends on what practice environment you're in, and if you can keep Jens and Rod's phone numbers. And for the first 3 to 5 years after I graduated from my fellowship, I was regularly on the phone with Jim Ogilvy.
And recognize, by the way, the point 13 of Colin Powell's 13 Rules of Leadership, and that is perpetual optimism is a force multiplier, and you certainly embody that, and you've inspired all of us, and I'm going to clinic with a big smile and a large dopamine surge in preparation. Dr. Luis Quartararo said, and again, I always love his interactions, wishing you weren't retiring, and that's exactly my sentiment, but you deserve it. And you have an invitation by Dr. Randy Davis, our good friend and Gold Pass member. Great presentation, superb career, congratulations, exclamation mark. Come visit Gibson Island when you come east next time. My wine cellar needs weaning, Randy. So on that note, your voice held up fabulously. You're tough as nails also after spine surgery yourself, so experiencing what you're successfully meted out so many times. The many insights were wonderful. And again, as Rod said, hope to stay in close touch with you. Thank you, Dr. Polly.
Awesome talks, David.
Thanks.